The Australian Institute of Family Studies found that in 2022, 1 in 6 older Australians experienced some form of abuse, with mothers being most likely to experience abuse from their sons. The abuse of older people is a complex health problem that has devastating physical, emotional, and social consequences for older people. The abuse endured can be either deliberate or unintentional, occur once or many times, and does not always have to be physical. Financial and emotional abuse are often overlooked due to their subtlety and include threatening or actually restricting access to family or friends, coercing to relinquish control over assets and income, or withholding access to finances required to meet the reasonable living expenses. Abuse of the elderly not only causes immeasurable and lasting damage to the individual, but can also lead to greater demands on the health and aged care systems, government benefits, and other health services. Various legislative policies enforced in Queensland apply to elder abuse, in an attempt to protect victims by outlining legal responsibilities for health professionals. Section 8 of the Domestic and Family Violence Protection Act 2012 indicates patterns of behaviour reflective of abuse, and further details each type in sections 11 and 12. The QAS CPM for suspected abuse similarly outlines crucial signs of actual or potential abuse and provides additional steps to follow in response. The Criminal Code Act 1899 supports these signs of abuse in Sections 75, 245, 328, 340 and 355, where associated penalties are listed when acts such as assault, threats, negligence and deprivation of liberty are found to occur. These abusing behaviours are clear violations as per Section 16 of the Human Rights Act 2019, and additionally Section 17 through to 25, where any deprivation to movement, expression, privacy or property are considered significant breaches. Perpetrators of elder abuse are often legally bound to the responsibility of providing care to the elderly, as per Section 6C of the Powers of Attorney Act 1998 and Section 11B of the Guardianship and Administration Act 2000. However, clear breaches to these acts are found to exist due to a loss of dignity and, as previously mentioned, human rights. Although paramedics gain excessive insight into elderly patients in the community, Section 50F of the Ambulance Service Act 1991 prohibits the disclosure of confidential information without patient consent. However, the ability to gain consent proves to be difficult due to the fear of reporting abusive family members among the elderly victims. Similarly, Section 144 of the Hospital and Health Boards Act 2011 inhibits paramedics disclosing suspicions of abuse, despite Section 1 stating the best interests of patients should be the main consideration in care. Section 147, however, allows the disclosure of information when approved by a chief executive, and only when deemed necessary to prevent serious risk to the life or health of the patient. Both physical and emotional elder abuse lead to serious health and social implications, impacting the overall quality of life of victims. Physical assault can not only cause injuries such as cuts or bruises, but in more severe cases has been linked to permanent disability and premature mortality. Negligence similarly leads to poor physical health, in the form of weight loss, poor hygiene, and exacerbation of morbidities due to withholding of medications. Psychological abuse often leads to poor mental health outcomes such as anxiety and depression in victims due to harassment, verbal threats, and intimidation causing feelings of hopelessness and fear. These emotional consequences often lead to social withdrawal, isolation, and lack of relationships. Evidence suggests elder maltreatment contributes to significant economic costs due to increased use of health, social, and legal services. Increased rates of elder maltreatment contribute to the increased healthcare costs due to higher demand for treatment and rehabilitation. With a rapidly aging population, suspected rates of elder abuse is projected to increase, alongside the current estimation of $20 million spent on hospital admissions, therefore further increasing the burden and financial stress on health systems. A framework designed for the pre-hospital setting involving an objective point scale based on identified abuse risk factors may assist increasing recognition of elderly maltreatment. In comparison to the subjective signs of abuse in the QAS CPM, the proposed framework could determine an elderly patient's level of risk by allocating points to signs indicative of abuse, where a greater value of accumulated points categorises the patient at significant risk. The advantage of paramedics entering patients' residence allows for an element of the framework to involve assessing the quality of the environment, such as access to food, medication, mobility supports, or any environmental hazards present. Similarly, a behavioural assessment of carers or family present can contribute to the framework, where signs of intimidation, harassment, coercion, or aggressive handling would lead to a higher score and thus higher risk of abuse. In addition, similar to the QAS-CPM, the patient's physical presentation would be assessed, where poor hygiene, behaviour indicating fear, or physical injuries would similarly receive higher scores. As elder abuse most commonly involves family members, elderly victims are likely to withhold information of maltreatment due to fear their care may be withdrawn or family members may be charged for offences. The lack of legal obligations of mandatory reporting by paramedics in Australian jurisdictions further restricts disclosure of patient information, therefore leading to underreporting of elder maltreatment. A legislative enactment imposing a duty on paramedics to report any suspicions or evidence of elder abuse, regardless of patient consent, would significantly increase early recognition and improve healthcare outcomes of victims. Furthermore, although mandatory reporting by paramedics may increase recognition, a lack of reporting services are available. Instead, referral and consultation lines exist, with limited capacity to provide advice. Therefore, a governing body must concomitantly exist in order for legal action to be provided and consequences to be rectified against perpetrators. Screening tools such as the Vulnerability to Abuse Screening Scale have proven significant reliability in identifying victims of domestic violence. However, limited evidence supports the pre-hospital use of this tool, indicating that despite consumption of time and resources, the development, research, and education necessary to implement a new screening tool could prove to be both clinically and financially pragmatic in addressing impacts on physical and emotional well-being of victims. In order to implement mandatory reporting and an associated reporting service, significant demand for finances and labour would be required from the Australian law reform. However, with such services, paramedics would gain the right to disclose concerns of potential or actual abuse and in turn improve the outcomes of elderly victims. With significant anticipation of an increased elderly population, the need for rapid intervention further supports these strategies.
Created using Powtoon.